Welcome to this January 2024 update for the Caregiver Supports Project. The Caregiver Supports Project aims to implement a continuum of placement resources that enable safe, stable, and supported placements for children and youth in foster care. There are two phases of this work. In Phase 1, which was implemented on January 1st, 2024, DCYF replaced the existing 4-level rate assessment system with a 7-level model that is based on the needs of children and youth in care. The new foster care level reimbursements associated with the 7-level model went into effect January 1st, 2024, and licensed caregivers will receive reimbursements at the new rates in February 2024 for services provided in January. One other change in 2024 is that CPA licensed homes will be paid directly by DCYF instead of through their CPA. The impact of this change is that CPA licensed caregivers will receive invoices each month starting in January 2024 that must be claimed in order to receive reimbursement. This is the same process DCYF licensed homes follow currently for reimbursement. There are a number of resources for learning about invoicing, setting up direct deposit, and registering for the provider portal, all available on the Caregiver Supports Project website in the payment. DCYF is also hosting Zoom sessions where caregivers can ask questions or get one-on-one assistance with specific payment issues. The schedule for these sessions is also available on the website under the payment section. Phase 2 of the Caregiver Supports Project is the implementation of a new Caregiver Supports contract to provide placement supports to both licensed and unlicensed caregivers. Pre-authorized case aid hours will be part of the placement supports available for Caregiver Supports levels 3 through 7. The Caregiver Supports contracts will be awarded to providers through a bidding process, and the contracts will be executed by catchment areas with implementations starting in 2024, with all catchment area contracts executed statewide in 2026. The contracts will roll out according to an implementation plan that is based on capacity to provide services and allowed legislative project funding for the next few years. The Caregiver Supports Project is part of DCYF's Thriving Families campaign. Thriving Families is made up of multiple projects and initiatives in the child welfare space that focus on prevention, supporting families and staff, and strengthening practice. The projects, including Caregiver Supports, are listed on the Thriving Families website along with links to fact sheets about each project. The Caregiver Supports Project is the culmination of several years of work, including research and extensive engagement and gathering of input from many different groups and individuals. Today's presentation focuses on the new Caregiver Support Level Determination process that started January 1st, 2024. The Caregiver Supports Project was undertaken to address several identified pain points in the old system. The Level 1 through 4 rate assessment process was 20 years old and needed to be reviewed and updated. It was also subjective, meaning it was difficult to establish reliability of any tool used to determine levels. Subjectivity also leads to unfair allocation of funding, with some caregivers over-reporting the needs of children and youth and others under-reporting needs. Using caregiver report of time spent caring for a child is not the best proxy for a child's actual support needs. Data found that the main reason a child or youth's level would change was not because of a change in needs, but because of a change in placement, so the child or youth was with a different caregiver. This led to a less fair distribution of supports, as some caregivers reported higher needs, while a different caregiver would report lower needs for the same child. In a subjective system, caregivers must continuously justify the reimbursement level, whereas in a needs-based system, the reimbursements are readily available at the time of placement for the known needs. A subjective system is also much more difficult to evaluate for bias. Bias cannot be eliminated if it cannot be identified. The previous 4-level rate assessment system did not clearly identify a child's needs. This made it difficult to link caregivers to the supports that are best suited for the child or youth in their care. It also made it difficult to develop contracted resources structured to support caregivers to meet the needs of children placed with DCYF. The 4-level rate assessment system also had a substantial gap in placement resources between foster care basic and BRS, which interfered with many children receiving their actual needed level of care to be able to thrive, and had the potential to lead to worsening conditions while in care. The gap created a risk of kids failing up into more restrictive settings because supports were not available at the foster care rates, but BRS and therapeutic treatment are more intensive services than are needed for a child who could be placed in a foster home with some additional supports. The project has several goals that were developed to address the pain points in the previous system discussed in the last slide. The goals related to Phase 1 are creating a transparent and data-driven payment methodology for reimbursement, which will be achieved through the new model that has been developed using data and feedback from many different perspectives, making resources available at the time of placement by identifying needs up front, providing caregiver resources that are based on the needs of children and youth and being able to serve a diverse population all the way up to BRS needs, increasing placement stability by providing caregiver supports based on the child's needs as close to the time of placement as possible, and striving for more parity in resource support or creating more fairness in how dollars are allocated by reducing subjectivity in the rate assessment process and using a tool that is regularly reviewed so that there are mechanisms for evaluating resource allocation and equity and system bias so as to be able to effectively reduce it. The caregiver supports model was designed to address the pain points discussed earlier and meet the goals mentioned in the previous slide. The model was developed based on feedback from many different groups representing different perspectives. Please watch the November project update posted on the Caregiver Supports Project website at the bottom of the site in the previous communication section to learn more about the history and background of the project. The Caregiver Supports model has several principles at its foundation. Those include objectivity, transparency, fairness, consistency statewide, supporting the caregiver to be able to care for children and youth with diverse needs, increasing foster care level payment rates, and closing the gap between BRS and level payment rates. Phase 1 of the Caregiver Supports Project was implemented January 1st, 2024. Phase 1 includes new caregiver support level reimbursements for licensed caregivers. The placement supports for licensed and unlicensed caregivers shown on this slide are part of Phase 2, which will start rolling out later in 2024. The Caregiver Supports model includes basic foster care or Caregiver Support Level 1, as well as 6 distinct support needs categories shown on this slide. Each support needs category is associated with a Caregiver Support Level 2 through 7. The Caregiver Support Level determines the foster care rate that licensed caregivers receive effective January 1st, 2024. The level will also determine the placement supports that all caregivers, licensed and unlicensed, will receive as the Caregiver Supports contracts roll out in Phase 2. Level 1 is the same as basic foster care. This rate was updated July 2023 and did not change January 1st, 2024. Level 2 is only for youth that are 12 years of age and older, so there is only a rate for the 12 plus age group. Anyone in a fully licensed home that is 12 years old and older will be a level 2 if they do not have any other characteristics that would put them into a higher level. There is a rate listed for age 12 plus in level 1. This is for initial license homes because all initial license homes will receive a basic foster care rate and are not eligible for level payments. If an initial license home becomes fully licensed, a caregiver support level determination will be completed for the children or youth in the home, and the caregiver will start receiving level reimbursements. As part of Phase 1 and the shift from the 4-level rate assessment system to the 7-level caregiver supports model, DCYF has implemented a new tool and process to determine the caregiver support level. This new tool and process replaces the rate assessment process used to assign level 1 through 4 prior to 2024, which consisted of an interview with the caregiver in the first 30 days of placement to determine the time spent caring for a child. As discussed in the previous slides, this was a highly subjective way to determine rates and did not necessarily capture specific needs of the children and youth. The rest of this presentation focuses on the new caregiver support level determination tool and process that is designed to be more objective and focuses on identifying the needs of children and youth. There is more information about the extensive work that went into developing the caregiver supports model in the November project update that is posted on the Caregiver Supports Project website at the bottom of the site under the previous communication section. For some brief history, DCYF contracted with DSHS's Research and Data Analysis Unit, or RDA, to research the needs of children in out-of-home care at the time of placement. The original research report looked at medical claims and administrative data for over 25,000 children in DCYF care between 2015 and 2018. RDA analyzed how different characteristics like mental and physical health conditions were related, and then identified distinct groupings of needs which became the levels. You can view the original RDA research report at the link provided in the slide. The original model in the RDA research paper had 10 levels. RDA refined this model using more recent groups of kids in care than the 2015 to 2018 group and narrowed down the indicators used. For example, the original report had separate categories defined largely by gender based on internalizing or externalizing behaviors. So these categories were combined into a single complex mental health category because although the behavioral expression was different, the underlying need was complex mental health for all of these cases. Additionally, juvenile justice involvement was excluded as an indicator because of the potential for bias. Note that substance use data is not included in the health history data because of federal privacy laws for this type of health information. After the statistical modeling was redone, the 7-level model as seen on the previous page emerged. DCYF is in partnership with RDA, and there is funding to continuously evaluate the caregiver supports model. It is not meant to be static. RDA and DCYF will be monitoring data, and the model is meant to be updated based on findings and identified patterns. The model can be refreshed over time and after additional engagement. This slide looks more in depth at the different categories of support needs identified through the RDA research as well as DCYF's conversations with different groups. These levels are not labels that are applied to youth. They are groupings of support needs that the caregiver needs to be able to provide support for the children in their homes. Chronic physical health conditions are defined by conditions that are chronic and are progressive. For example, this could be a progressive condition that has deteriorating health and decreased life expectancy, such as cystic fibrosis. It could also be a malignancy that is progressive or metastatic and affects life function, such as leukemia. It could also be a condition that is not progressive and does not have malignancies, but lasts longer than a year or is lifelong and requires treatment and additional care to maintain, such as diabetes. Developmental disability includes intellectual disability or other pervasive developmental diagnoses. This does not have to be a new diagnosis. It also includes language or learning disorder or motor or tic disorder diagnosis. DDA eligibility or service within the past 24 months would be another indicator for this needs category. Factors associated with the moderate mental health category are mental health prescriptions like psychotropic meds, anti-anxiety meds, antidepressants, and ADHD medications. Youth or children with a mental health disorder diagnosis within the past 24 months fit into this category. All youth in foster care will have some level of trauma they are working through. For the purposes of level determination, a provider needs to have made a DSM trauma diagnosis within the past 24 months, meaning a diagnosis included in the Diagnostic and Statistical Manual of Mental Disorders. The complex mental health category is defined by more acute mental health conditions. Factors that would indicate this level of need include antipsychotic or anti-mania medications, youth who have had suicide attempts or self-harm episodes that required medical attention in the last 24 months, crisis mental health services that have been provided in the last 24 months, or short-term inpatient services, including emergency department or emergency room stays or visits. This category also includes inpatient mental health hospitalization or long-term mental health treatment placements in the last 24 months. Children's long-term inpatient program, known as CLIP, or other long-term mental health services are in this category. Polypharmacy, which is defined as 4 or more psychotropic prescriptions for at least 60 days in the prior 24 months, falls in this category as well. If a youth has been in the emergency department for overdosing or poisoning in the last 24 months, it is in this category. DCYF has also identified other factors that are associated with higher support needs and would influence the level determination. These factors include evidence of sexually aggressive youth or SAY behaviors as defined by an SAY determination made by a regional SAY committee, an adjudication for a sex offense, or a youth who has a supervision plan for behaviors beyond normal sexual development. Substance use disorder is another factor and is defined as a youth actively using substances for a mood or mind-altering experience and/or treatment for substance abuse in the last 6 months. The final other factor is running away behavior as defined by running away 2 times or more per month overnight in the last 30 days. As stated previously in the presentation, DCYF will review the model regularly and monitor data and trends over time for any evidence that the identified support needs and/or the criteria that influence the caregiver support level determination should be modified to better serve families. One example of this commitment to adapting the model is changing the process for exceptional cost plans, or ECPs, to be reviewed by so that DCYF can track the reasons ECPs are requested and understand the type of needs that are not supported in the caregiver support model. If there is a trend that there are many ECPs for a specific condition, DCYF could consider adding that condition as something that would influence the level determination. The Caregiver Support Level Determination tool helps staff to identify conditions from these support needs categories so that the level can be determined. There must be documentation of the conditions that inform a level determination. This makes the process objective and focused on the identified needs of the child or youth. If a caregiver believes a child or youth has a condition that has not been diagnosed, the child or youth should be evaluated by a provider to confirm a diagnosis and begin any treatment as necessary. Exceptional cost plans can be requested for some circumstances to help provide additional support when it is needed if it takes time to be able to see a provider. The tool lists the support needs categories listed on the previous slide along with relevant conditions and criteria that are the basis of the support need. When staff indicates a condition is present, the tool produces the associated level. For example, if staff indicated a child or youth had a chronic condition like diabetes and did not mark anything else in the tool would return a level 3 for chronic physical health. If staff indicated diabetes and also an IEP for a learning disability, the tool will return a level 5 for developmental disability and chronic physical health. If the child did not have any identified conditions in the support needs categories, the tool would return either a level 1 for children under 12 or a level 2 for youth 12 and up because the tool also factors in age. DCYF staff use many different sources to gather information to populate the tool. Those sources include interviews with parents, the youth, schools, providers, caregivers, or other important people in the life of the child or youth. Staff also reviews information available in the child welfare system, family, such as completed screens, database information, and provider reports or discharge paperwork that has been attached to the case. The goal of the tool is to determine a caregiver support level and is not meant to capture comprehensive information for the purposes of care planning. That would be done with other tools or assessments. For that reason, if DCYF staff has documentation that a child is a level 7, they would capture that in the tool and then could be done with the level determination because that is the highest level. For example, if the youth discharged to DCYF's care and custody after being at the hospital for suicidal ideation, we know automatically that the caregiver support level is a 7 without doing additional research. This level would be entered into the tool without completing interviews or doing other research into family documents. If there was a documentation in family that a youth had a chronic condition, staff could mark this in the tool, but then would continue researching documentation and/or would reach out to interview sources and learn if there are additional factors that could increase the level. The process is designed to make sure that diagnoses are not missed and the caregiver receives the highest support level that is indicated. For that reason, DCYF will also consider health history data that is available from the Healthcare Authority, or HCA. This data comes to DCYF staff in the form of a health history level recommendation available in a report that pulls data from HCA and organizes it into the same supports needs categories that are part of the caregiver support level determination tool. If there was billing data in the last 24 months for a diagnosis that is associated with the support needs categories, the health history level recommendation will reflect this. For example, if there was a diagnosis for diabetes and no other billing data, the health history level recommendation would be a level 3. There are often times when DCYF will have more up-to-date or comprehensive information about a child's needs or conditions, especially since billing information can be significantly delayed depending on when a provider submits it, and billing data is also limited in scope. For example, it does not capture non-Medicaid billings or many outpatient therapy services. That is why DCYF will use many sources of information to make a level determination, inclusive of the health history recommendation. If the caregiver support level determination tool result is a level 5 and the health history level recommendation is a level 3, DCYF will determine a level 5 caregiver support. If the caregiver support level determination tool result is a 3 and the health history level recommendation is a 5, indicating there was a diagnosis for additional support needs in the past 24 months that was not uncovered in the DCYF initial research, DCYF will determine a level 5 caregiver support. DCYF always selects the highest caregiver support level indicated by the information sources and administrative data. DCYF acknowledges that not all children and youth in DCYF DCYF acknowledges that not all children and youth in DCYF will be able to be served by the caregiver support model. There will always be unique situations and very high needs that are not accounted for within the model. For this reason, exceptional cost plans can be requested to help when additional supports are needed outside of what is offered by the model. The next slide goes over a high-level process map of caregiver support level determination. The process depicted is one that DCYF will use for DCYF jurisdiction children. There will be a slightly modified version for tribal jurisdiction children to account for how DCYF works with tribes for placements. Tribes can do their own level determinations for tribal jurisdiction children and youth, or they can have DCYF do the level determinations. In either case, the tribe will not be asked to send DCYF documentation of medical records for tribal jurisdiction children. This belongs to the tribes. As soon as DCYF is aware of a need for placement, the Regional Placement Resource Specialist, or PRS, will be notified so the level determination process can start. Placement Desk will complete the child location app in order to alert Fiscal that a placement needs to be opened. Once the placement is opened by Fiscal, the PRS can enter the caregiver support level into Family to generate the level reimbursement. Per policy, the level determination must be entered and approved within 7 days of the placement. After the tool is completed, the PRS will also review the health history recommended level to see if there is documentation that would indicate a higher level. The PRS will update the level in Family if the health history recommended level is higher than level determined using the tool alone. Any updated entry must happen within 14 days of receiving the health history recommended level per policy. The health history recommended level requires that the child or youth has a Provider 1 ID. So if this ID is not available, DCYF will not complete this step. DCYF will continue checking for a Provider 1 ID up to 45 days before making the final determination without it. The PRS is responsible for completing a review of the level determination every 6 months, as is current practice. A caseworker or caregiver can also request that the PRS do a review at any time if the needs of the child have changed. Please refer to the Caregiver Supports Project website for up-to-date information about the project. You can visit the DCYF rules filing site to learn more about WAC changes that are associated with the project, or look at the foster care rate assessment policy. DCYF will put content about caregiver supports in Caregiver Connections and Thriving Families publications. There will also be additional project update presentations like this posted on the website in the previous communication section at the bottom of the website. The project website is the best source for information about the project. Tribes will have the option to do their own level determinations for tribally dependent children, starting with implementation of Phase 1, and will have the option to provide placement supports to their own members as Phase 2 implementation rolls out. Please contact Mandy Moreland if you would like to meet with DCYF to discuss the project and impacts to your tribe. You can view presentations specifically for tribes on the project website under the previous communications section header at the bottom of the page. If you have any questions or comments about the content in this presentation, please email the Caregiver Supports Project inbox dcyf.caregiversupports@dcyf.wa.gov. Thank you for reviewing this presentation, and we look forward to sharing additional information at a future date.